So good day. I would like to welcome you to the ATS Nursing webinar entitled The Science of Nursing. I would like to thank the ATS International Health Committee for inviting us to do this webinar, and it gives me great pleasure to introduce the others on this. So Dr. Anne Marie Russell from the United Kingdom, and she will share a little more about her background. Dr. Sarah Miller from the Medical University of South Carolina, and Charmaine Sim Pison from Singapore. And my name is Dr. Kathleen Lindell. I am the Mary Swain Endowed Chair in Palliative Care Health at the Medical University of South Carolina in Charleston, South Carolina. And Dr. Russell and I are co-leading this. So just for some background information, we thought that the topic, the science of nursing, is very important because of all the great work that nurses do around the world. And so today we're going to share a small collection of some of this work. And we will do questions and answers at the end. And so if you have any questions, please put them in the chat. And the last 15 minutes will be time for the Q&A. This webinar will be recorded and available in 2 weeks on the ATS YouTube site. And thank you again for registering. I'd like to share our agenda. So first, welcome and introductions. What I would like to do is I'd like to introduce Dr. Sarah Miller, and then Dr. Russell is going to introduce Charmaine. So I have the great pleasure of working with Dr. Sarah Miller here at the Medical University of South Carolina. She is a respiratory physiologist by background. So she was a physiologist before she obtained her nursing education. And her work is focused in rural patients with COPD and having them better understand how their respiratory mechanics work. And that's what she's going to talk to you about today, her particular program of research. With that, I'm going to hand it over to Dr. Russell.
Thank you, Kathy, and I'm delighted to introduce Charmaine Sim Payson as well, who is kindly joining us from Singapore, where it's 8:30 in the evening. Charmaine is doing sterling work as a nurse specialist with an interest in research. I had the privilege of visiting Charmaine in Singapore earlier in the year, and we're really looking forward to her perspectives from the evolution of nursing in serious respiratory illness in Singapore. Thank you, Kathy.
So first, I would like to review the agenda for today. So I'm going to talk for probably 5 minutes, not 10 minutes, on defining the key concepts for today's webinar, and then the role of palliative care in serious respiratory illness. And then Anne Marie will take over and talk about measuring what matters to patients living with interstitial lung disease. Dr. Miller will then follow with enhancing respiratory muscle function in COPD and the role of RESPFIT, her science. And then lastly, Charmaine will talk about nursing in Singapore, and then there will be time for questions and answers. I just want to disclose up front that I have to leave at 9:25 for an urgent meeting. So Dr. Russell will be taking over from at that point. So key terms, I'd like to go over some key terms just to kind of level set for everyone. So the first is, what is nursing science? And I'd like you to think about this and what your definition is. And the American Nurses Association in 1970 set this definition. It's the deliberate problem-solving process grounded in the biopsychosocial sciences of diagnosing and treating actual or potential health problems. And so think about that in your day-to-day work. I think that as nurses, one of the things that we do is not only do we care for patients and their family members, but in addition, we think, oh, why do we do it this way? And why can't we do it differently? Or why can't we do it better? And so I think that's really kind of a foundational perspective for nursing science. Um, I also think, and I highly endorse this, that patient-centered care, that when we include the patient in their decision making, that we include their preferences, their values, their beliefs. And what happens is that there will be a better engaged team. I like to call it that the patient is the driver of their bus, and that we need to honor what their wishes are. And then the last term I'd like to review is serious respiratory illness. There has been a change in the nomenclature in the United States in particular. You've heard chronic respiratory disease, you've heard life-limiting respiratory disease, end-stage respiratory disease. And within the past year or two, there's been this movement. It's called the Serious Illness Messaging Campaign. And now this has become a global uh, piece of work to entitle this serious respiratory illness. So what is SRI? It's a health condition that has a high risk of mortality and negatively impacts a person's daily life or quality of life. And this is across the lifespan. So this is with neonates all the way through to seniors. This picture, I just want you to stop and look at this and think of all the different locations that where nursing science can take place. So it can take place in the hospital, it can take place in the School of Nursing or the College of Nursing, where students are learning and becoming more proficient in their science. I think that is the bottom picture on the right. The thing that's really important is that in order for us to be successful, it needs to be interdisciplinary so that we engage all members in the team and remember keeping that focus of what can we do to honor and value what the patient and their caregiver wants. So palliative care in serious respiratory illness. So palliative care is something that I think is the essence of nursing. I feel very strongly about that because when we entered the field to be nurses, we just want to care for patients and be able to help them get better, or if they're not going to get better, help them have reduced suffering. So it's a specialized medical care for people living with serious illness. And according to CAPC, the Center to Advance Palliative Care out of New York City, it can be thought of, it's an extra layer of support. It's really there to help provide relief from the symptoms and the stress of serious illness for both the patient and the caregiver. And so our goal is that we want to improve their quality of life. According to the World Health Organization, it is explicitly recognized under the human right to health and should be provided through person-centered and integrated health services that pay special attention to the specific needs and preferences of the individuals. And I'd like to add one specific example. Sometimes the providers that you'll be working with will say, I'm already doing palliative care. And I challenge you to ask them, are you engaging all the services affiliated with palliative care? For example, the social worker, the chaplain, because as we recognize, when a patient has a serious illness, there are many caveats to this, and the patient can be very afraid, the family can be very afraid. So when you use these other resources, it can help to just improve the care that the patient receives. And with that, I'm going to turn it over to Dr. Russell.
Lovely. Thank you, Kathy. Just to check in, is this from your slide deck? Do I need to share my screen?
Yes, yes, you need to share and I'm going to stop. Thank you.
Okay. Is that working for everyone? Yeah. Despite the advances in technology, I think one always feels slightly uncertain in these circumstances. Firstly, welcome everyone. Thank you to the American Thoracic Society and the organisers for the kind invitation to present to you today, and particularly to Kathy Lindell for driving this. I hold a substantive chair at the University of Birmingham. That's Birmingham in the UK, not Alabama. And the aims of the talk today are to consider patient-centred outcomes in interstitial lung disease and think about how we measure these, considering holistic approaches and alongside the need for equity and quality of care. Okay, so many of you on the webinar today will know that interstitial lung disease is an umbrella term for many parenchymal lung disorders, and that progressive fibrosis is associated with physiological functioning impairment. And so we're going to think about how we can measure this in detail and bear in mind the equity of care. So alongside the progressive fibrosis and physiological functional impairment, we need to think about how we can optimise care that will include the evaluation of psychological well-being and social functioning, not only at the individual level, but also at a population level. And the city that I work in, Birmingham in the UK, has a population where 52% are representing global majorities, and therefore equality and equity are very much at the forefront of practice, as it will be for you in your areas of practice most probably, and also an important reason why we're having a global webinar today. So just in brief, when we're thinking about the heterogeneous nature of interstitial lung disease, we might want to pay attention to some of the shared and unique symptomologies. So sarcoidosis, connective tissue disease, related interstitial lung disease, and IPF are the most common fibrotic interstitial lung diseases, and we will focus on these today. And whilst this is not a talk about classification, I feel that I want to signpost you to having an appreciation of shared and different symptomologies across the classification. And I also want to signpost you to the latest classification, which I think is released ahead of print. I'm still working my way through this, and I think potentially you may want to do the same after this webinar as well. So classification of subtypes, I think, is important in our holistic assessment. And whilst frailty can occur independent of age, the number of comorbidities tends to increase with age. And so it's important to be mindful of this. And also to think about the volume here that we can see of unclassifiable conditions, which might be associated with greater uncertainty and possibly increased psychological distress. And patients in this category may fall between pathways of care. So for us as nurses working clinically and in research, we must be strong advocates for these patients, particularly for those who are not strong enough to advocate for themselves, and think about pathways to reassessment for reclassification and diagnosis of NDT, particularly when patient symptomology changes. So the patient pathway begins with diagnosis. What we see here is very much an investigative pathway, and that's necessary to optimise diagnosis. nurses are very well placed to coordinate these events and to liaise with the patients, but it's also important to consider how the patient is feeling, what they're thinking along this pathway, and how their functioning is impacted. And we can also think about self-management interventions here and support. Think about early serial monitoring and the use of symptom and quality of life measures, because if we're collecting this data at baseline, this can really help us to evaluate progression. So this ATS document was published in 2021 by an expert consensus, and it identifies 7 themes associated with patient-centered outcomes. And so we, as an expert committee, identified 7 domains, and these are align with patient-centeredness. And whilst they have clinical relevance, they are also important in research as well. And thinking about how to optimize outcomes, I think it's important to consider these in our practice and how we can capture, how we can measure patient-centered outcomes. And I do apologise, the gardeners have just decided to engage with lawnmowers, so hopefully you can still hear me okay. Let me know if it's a problem and I will try and close the window. So these are the themes that we identified as patient-centered outcomes: health-related quality of life, functional status, psychological and emotional well-being, as a precursor maybe to identifying those clinical domains of anxiety and depression. Symptoms, predominantly breathlessness, cough, fatigue, acquisition of knowledge, survival, and oxygen needs. And the conceptual framework around this, thinking about how we can measure them, often health-related quality of life, we may draw upon a generic measure rather than a disease-specific. For symptoms, that might be the same, but increasingly we have some disease-specific symptoms. When we're thinking about psychological and emotional well-being, we can unpick this and subdivide it into measures of depression, anxiety, possibly grief, stress, emotional freedom and confidence. And then functional status, which overlaps often with health-related quality of life, may include not only patient-reported outcomes, but different measures. Thinking about how we can measure oxygen needs and changing oxygen needs over time, and using that as an indicator for change in symptoms. Hospitalisation and survival and acquisition of knowledge, which also includes awareness and access to clinical trials. And these domains very much resonate with the EU PFF survey, which captured clinician and patient concerns on diagnostic delay in IPF and the impact of this on progression-free survival, quality of life and hospitalisation. And this has been echoed along broader issues for an Irish population study looking at unmet needs, and in the British and Australian research priority setting partnership work in pulmonary fibrosis. And more recently, it's been highlighted in a systematic review when considering both patient and caregivers' perspectives. So back to measurement, and let's have a quick focus on patient-reported outcomes, known as PROs in the US, but PROMs in the UK. But both mean the same thing and are interchangeable. So patient-reported outcomes are one element of clinical outcome assessment types. And so just a quick reminder when we're thinking about clinical outcomes assessment so that we're all on the same page. So we do have clinician-reported outcomes, and that might include things like the breathing pattern assessment tool, a measure of breathing pattern disorder, which is often physio-led. Performance-related outcomes, which might be the 6-minute walk test, and then observed reported outcomes, which are perhaps not so relevant to us, but maybe more commonly used in the field of psychiatry and adolescent health, and then patient-reported outcomes. which is looking at a report that comes directly from the patient about the patient's health condition without interpretation, and therefore should be completed independently. So let's have a little bit of a deeper dig into PROs. And these are ones that are commonly used in interstitial lung disease, not inclusively. So the St. George's Respiratory Questionnaire and the SGRQI and the CAT, which is the COPD assessment tool, were all developed by Paul Jones in the UK. They've been around for a long time, and there's some good validation for their use in IPF and for the generic SGRQ in CTD-IL, interstitial lung disease, with a minimally clinically important difference identified. The SGRQI has not really been used that much. It's a little bit shorter and takes out some of the noise from the generic instrument. Then more recently, we've got the LIPF, which is a modification of the ATAQ IPF, which is now more or less obsolete. And that consists of 2 modules of symptoms and impacts. And the IPF PROM, which is similar to the LIPF in being a health status measure. And we've got validation studies going on for both these questionnaires. As I say, this is not an exclusive list, and there are other questionnaires available. So I just want to highlight to you questionnaires that were developed by women clinical scientists in nursing. So this first one from Janelle York is the Dyspnea 12, which measures both the physical and affective components of breathlessness. It's a 12-item questionnaire, and it has been validated for use in asthma, COPD, and interstitial lung disease. And given the predominance of breathlessness in ILDs, it certainly has a strong utility. And the idiopathic pulmonary fibrosis PROM, which has been further validated in pulmonary fibrosis. And this is, again, a short, easy-to-use questionnaire of 12 items across 3 domains, measuring the physical and affective components of breathlessness, psychological distress, and fatigue, with further validation studies ongoing. This doesn't measure cough, but it behaves very well with an overall quality of life measure and adding in a visual analog scale to capture cough. We've got some nice data from a Sing Strong study led by a physiotherapist in Ireland. And you can see here that in terms of p-value, there was a very strong statistically significant improvement in the scores for the IPF PROM when compared to the SGRQ. So if you're interested in breathlessness, fatigue and psychological distress, it may be a more convenient instrument to choose for your patients. I'm conscious that we don't have much time today, but I did just want to flag these 2 guides that are a great help in thinking about how we use patient-reported outcome measures in practice, and also to think about how we assess measurement properties. I mean, that's a webinar in itself, but really to be aware of reliability, validity, and responsiveness, and perhaps look at the COSMIN website, which is a fantastic resource to assist in further information of different types of reliability and validity. So other measures, just in a top line, is to be aware of patient engagement and patient activation measures. They're starting to be used more frequently in interstitial lung disease, and there is no time really to dive into those today. But the patient activation measure and the patient engagement measure, which is a Porter Novelli, is worth being aware of, particularly if you're looking at assessing patients' ability to engage in clinical trials or a clinical intervention. We will just mention a patient-reported experience measure, the PREM, which is based on these core elements, which were defined by the Picker Institute. So looking at these patient-centered concepts about care and access to care, and emotional and physical comfort as well. And we looked at the patient-reported experience measure that had been developed in rheumatoid arthritis, very robustly developed, and engaged in looking at modifying this with permission from the original authors for use in interstitial lung disease. And this is now published as a preprint. The ILD Prem seems to be validating very, very well. It captures the patient's experience of care. And it is a disease-specific rather than a generic instrument. And just because we mentioned in the patient-centered outcomes workability, just a quick flag and a nod to sarcoidosis, which is a multisystem disorder. And this is not a PROM, it's not a validated tool per se, but a checklist. And this was recently published in Lancet Respiratory Medicine, but really helps in terms of thinking about supporting patients in a deeper dive into symptoms, but also thinking about how they're coping with daily life, and to support our patients who may need help in the workplace, or may in fact need help in transitioning from the workplace to the benefit system if they're no longer able to work. So knowledge about symptom science in serious respiratory conditions, I think, has been very much advanced by nursing science in all the different health settings that Kathleen alluded to. But we do need to develop this further and need to think about new research into symptoms. This should be providing our evidence base for all our clinical conditions, including serious respiratory illnesses, particularly for people who might need palliative care. And so our current and future efforts should very much focus on populations that require advanced symptom recognition and management to help with informed decision making. We need to work hard to do this. That moment of inspiration is great, but I'd say 99% of it is perspiration. So we must continue to work together to effect change. Thank you very much for your attention. And I will just quickly flag to you this fantastic book if you want to read more about patient-centeredness and patient-reported measures, edited by Kathleen. And I will now hand over to the delightful Sarah Miller. Thank you, Sarah.
Anne-Marie, can you hear me and see my screen okay?
Yeah, we can. Your screen's good. Thank you, Sarah.
Right, thank you so much. I enjoyed that. I really loved the talk about the measurement properties. I'm going to reach out to you later. I think my students would love to hear some of that. All right. Hi, everyone. I am so excited to share with you a little bit about some of my research in respiratory muscle strength training with COPD. I'm going to talk about my work through the nursing science lens. So, sorry, my screen around. Okay, so I'm going to talk about how nursing science is advancing this work on how we understand and help people living with COPD. So we're going to talk about some of the physiology, behavior, and function in COPD with respiratory muscle strength training, and how we target the mechanics of breathing to help patients improve their quality of life. I'm going to talk about our intervention, RESPFIT, which is respiratory muscle strength training for COPD, so respiratory fitness, and how we're using that with technology to help to motivate and engage patients and bring them care directly into their home. So, like I said, at first, I want to frame this through the nursing science lens. So we're intentionally connecting physiology, behavior, and function. And as we know, these three domains are inseparable, but especially for patients with COPD. From the physiological perspective, we know that chronic airflow limitation and hyperinflation are putting a constant strain on that respiratory system. So over time, that leads to weakened respiratory musculature, and especially the diaphragm. And this increases the work of breathing. So people have to work harder to breathe, and that contributes to a very distressing sensation of dyspnea. And of course, this is not all just mechanical, but it's also behavioral. So as dyspnea happens, patients start to learn to fear the sensations of breathlessness. So they may opt to avoid activities that trigger symptoms of dyspnea. So this might look like somebody avoiding going on a walk in the afternoon or going to the park, like with their grandchild, because they know they might have trouble breathing. And this results in further skeletal muscle deconditioning and this fear of dyspnea is dyspnea-related kinesiophobia. So it's the fear of movement because the fear of triggering dyspnea or not being able to breathe. And it is a very powerful driver of inactivity and decline in COPD. And then functionally, these physiological and behavioral processes converge. And as I said, the activity avoidance can drive further skeletal muscle deconditioning or decrease respiratory muscle strength, which we can measure with inspiratory pressure, and is coupled with the lower activity levels and worsening dyspnea. So with nursing science, we try to bridge those layers to understand how physiology influences behavior, how behavior affects function, and how we can develop targeted interventions to address all of these three. And this is the foundation for the intervention REST-FIT, which I will talk about today. So just a quick overview of respiratory muscle strength. So like I said, people with COPD or who are living with COPD experience substantial physical limitations. And one of the most distressing symptoms is dyspnea, that feeling of breathlessness or air hunger. So I always say, if you can't breathe, you can't do anything else. So it takes first priority in your brain if you're having trouble breathing. And dyspnea is multifactorial, and it has an affective component, so how you feel about something. And the physiological component is related to the increased breathing effort, hyperinflation, the weakened skeletal muscles, specifically the inspiratory and upper airway muscles, and loss of lung function. So it's also deeply psychological. So when somebody has a negative experience with dyspnea, they can learn to fear it or develop sensations of fear of sensations of suffocation. So this contributes to that dyspnea spiral where I was talking about, the fear of breathlessness, the dyspnea-related kinesiophobia. The resulting or subsequent behavioral adaptations, as I mentioned before, contributes to further deconditioning, but it also can contribute to isolation and an overall decline in quality of life. So if someone avoids going on a walk or going to engage in activities, this can increase the risk of isolation. So respiratory muscle strength training is a possible solution. In addition to traditional pharmacologic therapies, respiratory muscle strength training is something that a patient can do on their own to take control and have an active role in their care of their COPD. So RMST is well validated to strengthen the respiratory and upper airway muscles. This is the same way that we strengthen our skeletal muscles using a traditional weight training regimen. So you pick up your 5-pound weights and you do your bicep curls. You're doing this for your respiratory musculature. So patients use a small handheld device, and these are available on the market. This device that I'm showing here in the picture on the slide is one that Paul Davenport made that combines both inspiratory and expiratory muscle strength training with a two-way valve. And the patient or the person must overcome a pressure threshold to open the valve to breathe, and that creates a training effect. That pressure on the muscles creates a training effect that improves strength and coordination of the muscle. So over time, with a sustained adherence to respiratory muscle strength training regimen, this can result in increased respiratory muscle strength. But most importantly, it can contribute to relief of dyspnea. So we measure the improvement in respiratory muscle strength using PI max or maximal inspiratory pressure. And in some of our pilot work with respiratory muscle strength training or REST-FIT and COPD, we found that not only did we see an improvement in the PI max, but we also found meaningful improvements in dyspnea, but unexpectedly, or maybe expectedly, one of the things that we were pleased to see is that our patients reported that they had more confidence in managing their breathing. So we did some qualitative work to explore how patients felt following their training regimens, and they reported increased confidence and that they had an active role in their disease management. And they reported that they felt that it was empowering and accessible. They can do it in their own home. And as I said, it allows them to take an active role in improving their respiratory health. So we know that targeted inspiratory muscle strength training can improve or strengthen respiratory muscles and reduce dyspnea. But one of the problems is that these programs are underused. Just like with any behavioral strength training or exercise program, adherence is a challenge, and this requires continued or ongoing motivation, feedback, and consistency. So this is where nursing science comes in. So our goal is to interrupt that dyspnea spiral and empower patients to strengthen their respiratory system and restore their confidence in their ability to breathe and move and engage in the activities that they find meaningful and bring them joy. So our team has developed RestFit and Respiratory Muscle Strength Training and Fitness Program. And RestFit is a multi-component intervention that integrates home-based respiratory muscle strength training with remote spirometry, actigraphy, and daily symptom tracking. And it is framed within the self-determination theory framework to cultivate autonomy, competence, and relatedness, which are key motivators for sustained behavior change. Importantly, RestFit is also accessible, and we hope that it will tackle disparities in access to specialized respiratory care. So we've been piloting this with patients in rural and medically underserved areas and have found that this intervention is accessible at home, regardless of where the patient lives. So we developed RestFit with a series of 7 preliminary studies where we developed the digital platform. We have modified components. We use an iterative process where we ask patients and providers for their feedback, and we really have refined the intervention over time to make sure that we are including the components that the patients want and addressing their needs. So it now includes, the RestFit intervention includes educational content, respiratory muscle strength training. The digital component includes mobile health symptom tracking via EMA, motivational messaging, and respiratory function measures captured digitally. So we have remote spirometry, so patients can visualize their lung function and track their changes in real time. And all in an app. They also can report their symptoms, they can track their training, they can journal or log how they're feeling that day, and track their adherence over time. And we found that patients really liked this. They liked having clear, accessible information. So we have reminders in the app on how to do your training, what regimen you're following. They really liked the visual appeal and the ease of navigating through the app. So we found a lot of really help. At first, our app was a little bit clunky, and patients gave us a lot of feedback on like where to put a specific button or device or how to modify the EMA tracking. This was very helpful and insightful. The training protocol is a traditional 5-5-5. So patients do 5 breaths 5 times a day, 5 days a week. Initially, our patients also wanted to see a little bit more with the possible changes or just how their lung function looked. And that's why we added the remote spirometry over time. So let's look at these digital components a little bit more. So like I said, we track symptoms using EMA, so ecological momentary assessment, and that allows us to track daily symptoms like dyspnea, fatigue, cough, behavior, how are you feeling, how likely are you to go on a walk today, or how was your respiratory muscle strength training. We can modify the symptoms in this app modify the criteria in this app based on what we want to track. All of the information is hosted in one app now. The motivational messaging allows us to give personalized text prompts to remind people to train or log their symptoms, or if somebody is not logging in for some time, it allows us to prompt them. We found that patients really like this. 89% of our patients enabled this motivational messaging in the app. And then this is an overview of the overall program architecture of the actual intervention now. So like I said, we've added the spirometry, and I think this is one of the most powerful tools now in RestFit because it allows patients to visualize their lung function, and we found this to be very empowering. So we have nurses who can work with patients to help to educate them, like what do these numbers mean, what do these values mean, and provide them with information to track their disease themselves. We also found that many patients did not have access to this, especially in rural and medically underserved areas. So we were able to ship them portable spirometers to track this and measure this in their home. So we're hoping that this increases access for patients who are living in areas that do not have a pulmonary function lab or specialized medical care. And this is an issue, of course, all over the country, but in South Carolina, we have a large deficit of pulmonologists. I believe one of the recent publications included that there were 72, or in the low 70s, pulmonologists in the entire state of South Carolina. So that brings it out to like 1 per 72,000 or 73,000 people. So there is a clear disparity in access to specialized pulmonary care. So this is just a small piece that we hope will address this. So the takeaway or the summary here is that ResFit combines respiratory muscle strength training, real-time digital monitoring, and behavioral support into a single nursing-led digital model. So it is developed to strengthen the lungs, but also to cultivate confidence, motivation, and engagement by addressing those physiological, behavioral, and psychosocial dimensions of COPD. And ultimately, we hope that it will help our patients breathe better and live better. Thank you.
Thank you, Sarah Miller, for sharing. It's really impressive to see how you use app to help with patients.
Thank you, Charmaine.
Okay, I'll just share my slides just a moment. Okay, can you see my slides?
See them, yes.
Okay. Good morning, everyone. Thanks for attending the webinar. I'm deeply grateful for the organizer for this of the ATS webinar. Today, I'm delighted to share some of the initiative that was done in my hospital in Singapore. So the picture you saw here now is a Singapore landscape. I come from National University Hospital Singapore. It's a hospital established in 1985. We have total 1,200 beds and we serve about 1 million patients annually. And we offer about 50 medical, surgical, dental specialists. And we are the unique public hospital in Singapore that provide care for adult, women, children under one roof. And we house only pediatric kidney and liver transplant program in Singapore as well. The first project that I would like to share is our respiratory care nurse initiative. This project in the respiratory care, particularly in the area of respiratory management. The motivation behind this came from our observation that many nurses lack of confidence in adjusting ventilator setting. While we do have respiratory therapy in our ICU, this role is not widely available in Singapore across all the hospitals. So nationally, we have a national initiative to train ICU nurse in respiratory care. And we come together to standardize the curriculum and set up a course for the nurse in managing patients with mechanical ventilator or ventilatory support. So we want to define the clear roles and responsibility for ICU nurses in respiratory management. So with this course, and after they complete it, they are able to do assessment of the respiratory and more thorough manner. They are able to administer medicine, therapy like inhaler, nebulizer, oxygen therapy, and also transfer patient out of unit for procedure. They are able to educate patients and family on respiratory illness, treatment, self-care practice, smoking cessation, and also equipment usage. What's the benefit of them having upgrading them, enhancing them to the ICU? They can optimize patient care through precise titration of invasive and non-invasive. We implement and manage they can implement and manage non-invasive oxygen therapy, including high-flow nasal cannula, BiPAP, and CPAP. And they conduct regular assessment to determine patient readiness for spontaneous breathing test, facilitate timely weaning from mechanical ventilation to promote early extubation, and addressing the growing demand of respiratory care due to increased prevalences of respiratory disorder as well, in particularly to managing critical situations during pandemic. So it's a holistic and patient-centered care. We develop tailored care plan, coordinate follow-up, and advocate for respiratory initiative in the ICU and provide a holistic support, enhance the quality of illness. The next project I would like to share is our ICU-led palliative care. As we know, ICU is a place where our primary goal is to treat and cure critically ill patients. However, there are times when a patient can beyond the limits of medical treatment or advanced life support. In such situation, it became essential to shift our focus from curative to palliative, ensuring comfort, dignity, and support for both the patient and their families. We also observed who might benefit from palliative care were not being referred to the palliative care group. Why? Because our physician thinks that they are able to manage themselves. So if you could see from my slide from the pre-data, there's only 1.2% of the patient are referred from our pre to post data. Before we implement this, it's only 2.6% of the patient are referred to hospital palmet. So we see that then by nurse-led palliative care. So we started to screen patients with partial code, comfort care, dangerously ill, and presenting of symptoms. We start to review this group of patients. Over the 1 year data, we took the patient who demised from the ICU from February 2022 to 2023 for the pre-data and August 2024 to July 2025 for the post-data. So with the nurse-led palliative care initiation, we managed to review 41.35% of the patient, 1.2 to 41.35, there's a role for nurse-led palliative care in the ICU. So we hope this will make a difference to help the patient and family to transit during this difficult period of time. And we try to refer medical social worker early, and we try to pace them towards the situation where patient turns ill. Okay. So for integration of the palliative nursing care in intensive care unit, we noticed that we need to scale up our nurses in order to cope with this amount of patient group. So we developed a patient palliative care course to build up the capacity of the palliative care trainers. Our program equipped our nurses on symptom management and also assessment and communication skill for this dedicated group of patients. We also developed a comprehensive palliative care review process in the ICU and HIDE. After we screen the patient who are DIL, partial code, and comfort care, our trained palliative care nurse will review the patient to see if they are referred to medical social worker to take care of their psychosocial, emotional, and financial needs. We also make sure they are symptom-free, and we communicate with them early to pace the family if the patient is not doing well. And we also do whole family conference together with the physician to support them throughout this difficult time. So in our ICU, we are trained nurse in palliative care to be more compassionate, patient care, centered care, and this course equip them with essential knowledge and communication skill to better support critically ill patient and their family. So some of the outcome that we took out from after implementation, we managed to have improvement of stopping the non-essential medicine by 41%. And we also stopped non-essential blood check by 30%. And we decreased the vital sign monitoring in the ICU so that the patient won't be hooked onto the monitor most of the time. Before this, there wasn't this initiative. So subsequently, after we start, we managed to improve about 89%. And we refer MSW, which is a medical social worker, from 68.5 to 75.9%. To start with, the medical social support is already quite good, but with our implementation, we managed to achieve 7.4% more. So we also want to enhance our nursing role beyond ICU. We want to find out how is our patient after transfer to the gen ward, and we also want to prevent readmission to the ICU. And when we notice this group of patients, if they happen to readmit, it's because there may be some unfamiliar cases for the gen ward because of the low caseload that they take for patient may have tracheostomy or chest tube to different general ward, so their knowledge may be insufficient. So we started to implement a ICU liaison service. We review patient when they are transferred out from the ICU the next day to make sure things are followed up, how patients are coping, and also to ensure patient with certain care are being taken care of. So before we start this, we came up with 7 criteria that how do we come up with these 7 criteria? We analyze the patient who have frequent readmission back to the ICU. So with the data analysis, we come up with these 7 ICU criteria to review for patient who transfer out from the ICU. So if patient in the ICU have continuous non-invasive ventilator, we will review them the next day after transfer. That include a high flow nasal cannula without intubation, post-cardioversion in ICU, tracheostomy patient, and patient discharged with invasive line like chest tube. And the blue color PICC and central line, we took it out about 3 years into this initiative because we noticed that patients who are in oncology ward, the nurses are very well versed in managing PICC and central line. So we don't see a need to follow up on this group of patients, and therefore we exclude them. Same for dialysis catheter. Nurses in renal wards are very good in managing this catheter, so we also drop them off subsequently. We do review EOL care patients with anesthesia without palliative team follow-up in the gen ward. So we will follow up the patient in the gen ward. And we also have following high flow nasal cannula in the gen ward, and we will also take up to the ICU consultant or the team request that they think that this patient needs special needs, and we will also follow up on the next day. So these are some of the criteria that we will see patient after they are transferred out from the ICU. So for these, we managed to have role expansion for assistant nurse clinician, and we managed to spread it across all our ICU and high dependency in the hospital. And this closed the knowledge gap and provide education for the gen ward nurses who seldom have encountered with all these cases, but they also learn how to manage these cases with support. So last year we managed to, the background of this is in our hospital, high flow nasal cannula in the past can only be nursed in the intensive care unit. So this take up ICU space. So we had a collaboration with the general ward to take up patients who have high flow nasal cannula, but we will support them if they need any troubleshooting or any nursing care issue. So with this, we can reduce ICU admission and less need for patient to be admitted to the ICU. We can enhance patient comfort. Patient experience greater comfort with lesser monitoring device if they are in the gen ward. It can lower hospital costs because ICU cost is higher than gen ward costs. And we also empower the gen ward nurses to gain the ability to care for a diverse range of patient group and support for end of life, and also patient with maximum high flow nasal cannula support patient can spend their final moment in the gen ward rather in the ICU with more family member and less device at the bedside. So with this, I will end my talk. Thank you very much.
Thank you very much, Charmaine. Excellent. If I could ask you to stop sharing, and then we will come together, and we're happy to take any questions. I just can't access the chat at the minute.
Okay, give me a minute.
Yeah, that's perfect.
Fine. I think I unshared already.
Yeah, no, that's perfect. I think you stopped sharing. That's great.
Okay.
Sarah, are you able to access the chat at all?
Yes, I am. I see the question in there. Do you want me to read it?
That would be fantastic. Thank you.
Great. So this is a question from Dominic Paula. Sarah, thank you for your presentation. I have a couple questions regarding the RestFit platform. Is the patient data entered into the RestFit personal health record linked to the patient's EHR, allowing office staff to view or interact with it? The answer for that is no, it is not right now. It is a separate provider interface, and I'm hoping, or we're hoping, that in the future we will be able to integrate it, but that would be further down the line. Additionally, could you describe the team that supports and responds to patients using this platform? That's a great question. So we initially had our study coordinator working with this, and then we identified that that was not sufficient because patients had questions that were beyond the scope of the study coordinator. So we added a nurse practitioner into our study, our most recent study, who worked with patients and helped to explain their pulmonary function test results and their treatment. We also have a respiratory therapist who works with the digital platform. So the respiratory therapist helps to coach through the technique of using the spirometer and getting 3 breaths, doing it accurately, all of that. We are currently, or we will be starting on some next steps where we will be evaluating an avatar to train patients and using the spirometer. And we will be looking at that compared to self-directed versus RT, respiratory therapist guided. And then the third question, are these patients pulmonary office staff members? And if not, okay. And if not, how does your team coordinate with the patient's pulmonary care team? Yeah, so that, thank you. So I kind of answered that, but I'll answer that a little bit more explicitly. So patients patients have access to all of the data from their remote spirometer and their EMA of their symptoms and all of that. So they can share that with their pulmonary provider. And right now we don't have, like I said, there's no interface in the EHR. So we're just approaching this from the research perspective. But we hope down the road that this can all be integrated. That will be a much larger scope of a project. And then Koa says, Dr. Miller, can you share about the cost? Yes, I'm not actually quite sure what that comes down to, cost per patient. So as I said, it's been multiple studies that we have where we've been building the pieces of the intervention. And we finally have a larger scale intervention now to roll out. So I don't know what that would look like from a healthcare reimbursement perspective. It also will depend on what is reimbursable and what is not. As you know, that is shifting with Medicare reimbursements and yeah. So do you have qualitative data that is theory informed to show the mechanism or outcome of RestFit? So thank you. That is a great question. And yes, we are working on analyzing some more qualitative data right now that is framed through the SDT. And one of my PhD students is leading that study and analysis. She conducted the interviews, and we hope to be publishing that soon.
Okay, that's fantastic. Some great questions there. I might add, sort of picking up on the cost element, a question for Charmaine, which I think you have achieved a great deal, and I'm really impressed that you have access to a medical social worker to whom you've increased referrals, and I guess also the referrals to palliative care. And you also intimated that you've had some cost savings because you're not using an ICU bed, but able to step the patients down to a ward environment. But I was wondering, Charmaine, how that works with the business case. And I'm not, people on the webinar might not be so familiar with the health model in Singapore, whether it's a public or a private public model, and how you financially support those increased referral patterns.
If we are a public hospital, but we do have private and also public patient together. Oops, I think I'm losing you. I couldn't hear you very well.
Yeah, okay. I think we can, yeah, I think we're having problems with your sound, Charmaine. And maybe you should take your video off and then we just hear the sound. Do you want to take the video off? Because that might help with the quality of connection.
Okay, is it better now?
That's better. Yes, thank you.
Okay, so in our hospital, we do have private and public patients. But it doesn't matter to us whether they are oh you oh no, I think I cannot hear you.
Yeah, no, you're back with us. I think we just lose you intermittently, but we can put the sentence together. That's fine. Do continue.
Okay, so it doesn't matter to us whether patient is public or private class. We treat them the same, and if they require any intervention, we will still place them to where they will require.
And in terms of staffing levels, have you had to increase the number of medical social workers or the palliative care consultants, or is the workload manageable?
The palliative care consultant in our institutes is increased slightly, but it's not enough for the whole population. So what we are doing is we increase the intermediate nursing trained palliative care nurse to buffer off. So we will take the first step to review the patient. If we have complex case, we will discuss with our palliative care consultant. So we work in a different model.
Yeah, no, I understand. That's lovely. Thank you, Charmaine.
Thank you, thank you.
Yeah, I'm sorry, Sarah, I still can't access the chat for some reason. Do we have any further questions?
We do. The next question is for you. So this is from Mercy Paul Hill. As a PhD student studying ILD, I have been very interested in your work, Dr. Russell. Currently reading up on the AMBOX trials. I'm curious how you decide which PROMIS or patient-recorded outcome measures to use or adapt, particularly when balancing statistical robustness with what patients genuinely find meaningful in their daily lives.
That's a great question. Thank you. And I guess it depends very much on the research. And so one thing that I'm always mindful of, particularly with a clinical trial, maybe thinking about the minimally important clinical difference and not just taking that from one context to another. I think that every questionnaire we use should have multiple MCIDs depending on the population and the type of study it's been used in. I guess it's important to think whether you want a symptom measure or a quality of life measure. So certainly the St. George's Respiratory Questionnaire and the SF36 and the shorter SF12 are very good quality of life measures. If you're thinking that you might need to do some economic evaluation, a good health utility measure might be the EQ5D or the EQ, there's shorter versions available now. Or if you're doing a really deeper dive into symptoms. So, for example, if your study was focused on cough, you would, I think, very importantly need to pick up breathlessness, because I think there's an association between breathlessness and cough that we didn't quite understand. But from a psychometric perspective, they're very much interlinked. But if you were wanting to do a really deep dive into cough, you would want to use a cough-specific questionnaire. And for me, that would probably be the Leicester Cough Questionnaire. It is long, but from looking at data sets that I've used and using factor analysis and RASH, it's really difficult to reduce the cough items down. It's a complex thing to measure from a self-report viewpoint. I think the IPF PROM, the PF PROM is a good measure for breathlessness, fatigue, and psychological distress. But I guess the other thing is thinking about questionnaire burden as well. So probably the shorter questionnaires that are compliant with the FDA criteria. So Jeff's work is very compliant with FDA criteria for PROMs, as is mine and as is Janelle's and Paul Jones. So that's something to think about too. Thank you, Sarah. Thank you for the question.
Yes. So that's it on the questions now.
Okay, and I think we probably are about time. We're about 5 minutes over. So unfortunately, Kathy's had to leave, but just to iterate, thanks to Kathy for driving the organisation of the webinar. Thank you to Sarah Miller and to Charmaine for your fabulous talks. Great to have a session that's focused on nursing science, and may there be many more. And thank you to everyone for joining today. And we, as always, appreciate feedback on how we can improve going forward. So have a lovely day, everyone. Thank you.
Thank you.